Proper positioning plays a large role in obtaining quality radiographs and will help in reducing personnel exposure by preventing retakes. This segment will demonstrate most of the techniques used in radiographing various anatomical parts in small animals and show the use of devices which will assist in allowing the operator to be further away from the exposure area. We will also use radiographic examples of most of the areas demonstrated and discuss the criteria of recognizing proper positioning. The head is one of the more difficult areas in small animal to obtain quality positioned radiographs. Also, because of the large amount of bony tissue and the superimposition of many structures, special views and angles must often be used in order to delineate certain anatomical areas. It is also an area that is almost impossible to obtain quality films without chemical restraint. We will demonstrate the following views and show examples: a lateral, a ventral dorsal, an open mouth, a frontal sinus, obliques, and then dental film. This shows an animal being positioned for a lateral skull. Notice that the animal is under general anesthesia, and you must be aware that the anesthesia equipment, such as a tracheal tube, can add density and should be removed from the field as much as possible. The animal is on its side, and a wedge has been used to raise the mandible so that the midplane of the head is parallel to the tabletop. We are now measuring the animal. Note that the ear must be removed so it does not add density over the skull during the radiograph. The measurement was made at the thickest part of the skull. We are now collimating down to the area of interest. There are really two choices when producing a lateral radiograph. One would be to do primarily the calvarium. The other is to do primarily the nasal area. Since these two are much different in density and thickness, different techniques will be required depending upon which area is of prime interest in your lateral radiograph. You center the beam if you're to do the calvarium over the zygomatic arch. You'll notice where we have pointed and where the X of the collimator is positioned. If we're to do the nose, then the beam must either be extended or slide the beam cranial so that only the nasal cavity is within the primary beam. This shows if we're going to do just the nasal area, the measuring would be much different, therefore the technique would need to be adjusted. This shows a frontal view of the animal, showing that the midplane is horizontal to the table and that the animal is in a proper position. This shows a lateral radiograph of the head, including the skull, the nasal area, and the mandible. Notice that all the bilateral structures are superimposed in a well-positioned film. Structures such as the mandible, the tympanic bulla, the frontal sinuses. Also notice that in this radiograph the hard palate is a very dense line, since the hard palate is perpendicular to the primary beam and is seen on edge. Also note that the mouth is open, which prevents most of the superimposition between structures of the mandible and the maxilla. This film shows primarily concentration of the nasal area of the skull. When this type of radiograph is made, the technique is usually less, therefore more detail can be seen in the nasal area. Note that there is continued superimposition of the frontal sinuses, and the hard palate is still a very dense line indicating the primary beam is perpendicular to it. This shows the animal being prepared for a VD skull radiograph. Note the animal is in a V-traw to add comfort as well as maintaining the body position. The legs are being taped and are going to be pulled back across the thorax, which assists in getting the neck and head positioned properly. The head needs to be positioned so that the hard palate is parallel to the tabletop. This shows the measurement of the thickest part of the skull in order to set the proper technique. Then we're going to demonstrate the use of foam blocks under the neck so that the neck is extended, allowing the head to become properly positioned. The endotracheal tube and the tongue need to be centered. The ears need to be pulled away so that they are not adding density over the skull area. You may even want to consider whether you remove the endotracheal tube to reduce an artifact on the film. The beam is centered over the area of primary interest, and the collimation restricts the beam to just that area of which you are interested. A right or left marker must be placed so that you can properly identify the film once it is processed. A quality position VD radiographs of the skull should be based upon the symmetry of the anatomy. Note in this particular film that the symmetry of the zygomatic arch relative to the primary skull is equal on both sides. The mandible is equal and well positioned in that both are the same size and shape. Also note that the frontal sinus area is equally spaced between the rami of the mandible. The median septum is in a straight line since it is perpendicular to the primary beam and shows up as a very dense area. On the previous radiograph and position, the mandible was superimposed over the nasal area, which makes interpretation of this area more difficult. A method of positioning which helps with that problem is this open mouth view. In this open mouth view, the maxilla is taped to the table, keeping the head in a horizontal pattern, and then the mandible is taped open so that there is not the superimposition of the mandible over the maxilla. One of the advantages of this plastic frame is that it gives a good place to tape the mandible, as you can see. The tube and the tongue must be displaced to the side or to the middle under the mandible so that they will not superimpose over the area of interest for this radiograph. With this view, you can extend back to about the frontal sinus area of the cranial calvarium. This angle shows that the mouth is symmetrical and the mandible is back so that the nasal area can be visualized without the superimposition. It helps in this kind of a view to angle the tube head slightly, and the more angle that you put on the tube head, the farther back towards the frontal sinus area you can visualize. On this VD radiograph, open mouth, you will notice that the mandible is out of the way so that greater detail can be seen in the nasal area. You will notice on this film that there is some increased density in the right hand nasal cavity compared to the left. With the open mouth view, you are more confident that this density is not created by the tongue, therefore the confidence that it is a real lesion is increased. This special view of the calvarium is to allow visualization of the symmetrical frontal sinuses without any superimposed structures. After this film is made, it is so specialized that other areas of the film should usually be ignored and not interpreted for any other reason because of the distortion. You'll notice that the nose is taped to the frame, and the nose is basically pointing at the X-ray tube. The measurement is made from the medial canthus of the eye to the back of the skull to establish the technique. This particular positioning can also be used if you pull the nose more ventral and increase the technique to provide a frontal view of the calvarium. This is often useful when there is fractures and you're trying to look at the symmetrical shape and density of the calvarium. The beam is aimed almost between the eyes, and the collimation is to bring the beam down to just the anatomical area in which you are interested. Markers should be used because, again, due to the symmetry, the right and left sides of the skull cannot be differentiated on the radiograph. With a properly performed frontal sinus radiograph, the symmetry of the frontal sinuses is very obvious. With this projection, you can determine the symmetry of the density within each of the frontal sinuses, as well as being able to compare the erosion of bone that may occur with neoplastic involvement. On this particular radiograph, you will also notice 2 lead pellets in the soft tissue around the sinus area. This oblique view is to demonstrate the tympanic bulla and the temporal mandibular joints without superimposition of the right and left sides. To properly position the animal for this view, the head must be oblique so that this superimposition does not occur. Note that the mouth is held open with a piece of gauze over the canine teeth. This assists in allowing for reduced superimposition. You will notice that the nose is dropped and the mandible is not propped up as it was in the true lateral view. To see the opposite TM joint or tympanic bulla, the animal must be turned over and the film repeated using the same oblique positioning. The markers must be placed properly so to identify the projected right and left sides of the anatomy. This film shows an oblique view of the tympanic bulla and the temporal mandibular joints. Note that the right and left TM joints and tympanic bulla are not superimposed. On this particular film, the right tympanic bulla is cranial and the left tympanic bulla is caudal. The markers were placed at the time of exposure to identify the right side versus the left side. This is an open mouth oblique mandible view primarily to visualize the teeth and each of the hemimandibles so that fractures could be detected. The obliquity in this case is exaggerated so as to separate the hemimandibles. The mouth is held open with 2-inch gauze. You must label the view so that the correct side is identified. This film shows an oblique of the mandible. The more dorsal hemimandible is identified with an R for right. Note the greater detail in the teeth and the bone of the right hemimandible compared to the left. To make a similar view of the left hemimandible, the dog would be turned over and the exposure repeated. The maxilla was not well visualized on the oblique mandibular view. To visualize the maxilla, the rotation of the head must be made around the axis of the nose. The mouth is held open with the gauze, and the mandible is elevated to create the rotation around the center point of the maxilla. Markers must be placed properly, and the animal must be turned over and the view repeated to visualize the opposite side. This is a properly positioned oblique view of the maxilla. Note the separation of the two arcades of teeth. The lower one is best visualized. There is an error on this film which could cause the film to be repeated. There is no left or right marker, therefore it would be difficult to determine the side of pathological changes. This will show a demonstration of intraoral radiographs using various types of film. In this particular case, the film is placed inside the mouth so that there is no superimposition of either the maxilla or mandible, whichever the case may be. This shows the use of dental film, which is packaged in relatively small units and can be used in an intraoral situation. This is non-screen film, therefore it does require much greater exposure than we have been used to with screens in cassettes. This adds to the possibility of greater technician exposure during this procedure. We must cone down so that the beam is controlled to the greatest extent. Non-screen film is also packaged in larger, more easily obtained units. The exposure is approximately the same for this type of film as the dental film. It is somewhat larger and may be easier to process under some conditions than dental film. Regular cassettes with screens can also be used, particularly in some of the larger breeds. These screens allow a much reduced exposure, which is beneficial to personnel safety. The large cassette is more difficult to get back into the mouth, so you may be limited into the part of the anatomy that can be visualized using regular cassettes. This shows an intraoral mandibular bradygraph. Two images have been created on the same film. Note the high detail and the lack of superimposition of any other anatomical part which would confuse the interpretation. Another difficult area to position accurately is the spine. The spine is usually divided for radiography into the cervical area and the thoracolumbar area. This is because most of the diseases of which can be diagnosed occur in these two locations. Views common to both areas are the lateral and VD view, giving a complete examination of that part. Good position of the spine usually requires anesthesia. An exception would be the initial films of a recently injured patient where positioning and manipulation of the animal could further damage the spinal cord. When spinal radiographs are made, it is difficult to palpate the spine itself so that you can have proper positioning. The spine is actually controlled by positioning the head, the thorax, or the pelvis accurately. This then assures the proper positioning of the spine. The legs are taped and pulled back, and then a sponge can be used to prop up the head and control the cranial end of the cervical area. Sponges are then placed under the neck so that you can reduce the sag of the cervical spine. The wings of the atlas must be palpated to ensure that the cranial portion of the spine is accurately positioned. Tape can be placed on the canine teeth in order to apply traction to the head, thus reducing the sag of the cervical spine. Measurements for determining technique should be done either close to the head or close to the thoracic inlet so that the technique is set for the thickest part of the body. The central beam is over the central mid-cervical spine, halfway between the tympanic bulla and the thoracic inlet. This film shows a lateral view of the cervical vertebra. The film should demonstrate the vertebra from the atlas completely through to the first thoracic vertebra at the thoracic inlet. The determination of a well-positioned film is to be able to see the wings of the atlas superimposed so that they're not extending ventral to the body. Also, you need to be able to examine the sixth cervical vertebra to see that the transverse processes are evenly matched as they extend ventral from the vertebra. This positioning will show a VD of the cervical vertebral area. It is much easier if the animal is under general anesthesia. The problem with general anesthesia is the endotracheal tube, therefore we will remove that before exposure. The control of the neck is primarily by accomplishing the proper positioning of the head and the thorax. The animal in this case is in a V tray, which assists in positioning the thorax properly, and then with the tape on the canine teeth, the head can be positioned in a proper VD fashion. The ears must be pulled out so that they are not underneath the cervical vertebra. Sponges may be used in the middle of the neck so that the middle of the vertebra is supported and does not sag. The exposure must be properly centered from the base of the skull to the thoracic inlet. The palpation of the atlas wings helps you. Markers, if you are coned down properly, may have to be placed on the animal rather than out at the side where they would not show. We are showing that the tube is now removed so that we would not have the confusing shadows of the endotracheal tube over the cervical vertebra. On the lateral view, you can see that the animal is positioned properly, and one of the adjustments which can be made which assists the quality of the radiograph is to angle the tube slightly so that the primary beam is more parallel to the intervertebral disc spaces. This is an example of a well-positioned VD cervical spine. You will notice that the dorsal processes are noted end-on, superimposed over the midline of each vertebra. This is probably the best criteria for assessing a well-positioned VD cervical spine. The animal would be placed in lateral recumbency to do a thoracolumbar spine. Tape is placed on the fore and hind legs so that the legs can be pulled forward and backward and apply tension to the spine. This tension helps reduce the sag in the lumbar spine area. The animal is palpated so that it is horizontal. A sponge can be placed under the sternum so that the sternum is lifted, assisting in this proper positioning of the spine. The measurement is taken over the greatest bow of the ribs, since the thickest portion needs to be penetrated so that the film will be dark enough for proper examination. The center of the beam needs to be at the T13L1 junction, and then the beam is collimated to just showing the vertebral column. Note the collimation and the thoracic inlet to the sacrum can be visualized. This is an example of a lateral view of the thoracolumbar spine of a cat. To determine a properly positioned film, the dorsal bow of the ribs need to be equal and not separated, and the transverse processes of the lumbar vertebra also should be superimposed. You will note in this film that the hemipelvises are also very well positioned over each other. This shows the positioning for a VD of the thoracolumbar spine. You'll notice the animal is in a V-tray, which is of great assistance in trying to remove the personnel from the room. The tension is placed by using tapes on both the fore and hind legs so that the animal can be held in an upright, perfectly ventral dorsal position. The sternum and rib cage can be palpated in trying to assess whether the animal is in the proper position. Concentrate again on looking at the pelvis and the thorax as the major control of the positioning. The measurement is made at the greatest depth of the thorax in order to set the technique. The beam is centered at the thoracolumbar junction. This will allow a major portion of the thoracic and lumbar spine to also be visualized. The collimation needs to be down to just the width of the spine so that the scatter radiation is reduced in the rest of the animal. And again, we show the marker being placed on the animal right at the side so that it can be seen. This shows a VD of the thoracolumbar spine. The criteria for a properly positioned film is the symmetry of the transverse processes of the lumbar vertebra as well as a view of the ribs. And the most crucial thing is the end-on view of the dorsal spines superimposed over the midpoint of each lumbar vertebra. We have completed the positioning on the skull and spine areas of the body. Next, we will show and demonstrate the proper positioning for the major radiographic views of the appendicular skeleton. The first area to be considered is the shoulder. We will demonstrate a lateral and a caudal cranial view. Radiographs of the shoulder are much easier to obtain with general anesthesia or at least sedation. The shoulder of interest is placed down and closer to the film. The leg of interest is pulled forward, and the opposite leg, or one not interested in, is pulled caudally. Do not pull the upper leg back over the thorax, but keep it extended. The head and neck is then pulled in roughly a straight line with the upper leg so that the positioning is like a T. The acromion and greater tubercle is palpated so that the shoulder can be identified. The shoulder needs to be cranial to the thoracic inlet. A marker is placed on the film so that the proper leg will be known. The measurement is made and the technique is set. The beam is then centered over the acromion or the shoulder area and collimated down to where not much more than the neck of the scapula and the proximal inch or two of the humerus is visualized. This shows a properly positioned lateral view of the shoulder joint. Notice that the bony structure of the scapula and humerus are cranial to the thoracic inlet so that there's no rib or sternal superimposition, and it is also ventral to the cervical vertebra and the trachea. This demonstrates the positioning for the caudal cranial view of the shoulder joint or the scapula. The patient is placed on their back. The limb of interest is pulled forward. The shoulder joint is identified so that the position of the beam can be made properly. The measurement is made so the technique can be established. The head is pulled away from the extremities so that the thorax is rotated slightly and therefore no superimposition of ribs over the bony structure of the foreleg. You'll notice that if the animal is anesthetized, placed in a tray, and tape is used, that the operator can completely leave the room. The beam is centered over the shoulder. but the shoulder must be palpated to be sure in this area where it is located. This shows a radiograph of the caudal cranial view of the shoulder and scapula. This is the ideal view to visualize the scapula with no superimpositions. Notice that the dog's head is at the bottom of the radiograph or the screen. The head of the humerus is also noticed at the bottom of the screen with the scapula extending dorsally. This shows a less stressful position for obtaining a tabletop caudal cranial view of the shoulder or humerus. Notice the cassette is propped up and the beam is angled to hit the cassette perpendicular. This less stressful technique is important in post-op radiography. The next area for consideration is the elbow. We will demonstrate how to do a lateral view in the normal extension position, a flex lateral, which is primarily for viewing the anconeal process, and the cranial caudal view. With the elbow being less than 10 centimeters, tabletop technique is preferred. This allows us to reduce the exposure considerably. The leg of interest is pulled forward. The elbow may be propped up with a sponge under the olecranon. The leg that is not being radiographed is pulled backwards so that it can be out of the way. With tabletop technique, it is easy to split the film so that two exposures can be obtained on each sheet of film. With good collimation, as is being demonstrated here, there is very little scatter radiation which will fog the other side of the film. This shows a medial lateral view of the elbow joint. A properly positioned film will have both condyles superimposed over each other. That is noted in this film. Note in this that for the tape that was underneath the foot when we started to move the leg. This tape was placed on the cassette at the previous exposure so we would remember which end of the cassette had been exposed. This helps prevent double exposures. It is also worthwhile to keep the body part going in the same direction, which we are demonstrating, because of the ease of interpreting the films that way. The flexed view is primarily for viewing the anconeal process as it is pulled away from the medial epicondyle. Keeping the leg flexed but extended, the extension of the shoulder is important so that the elbow is ventral to the thorax with no superimposition. The beam then is centered on the elbow and the leg is maintained in a lateral position. This shows a flexed medial lateral view of the elbow. This view is particularly useful in the evaluation of the anconeal process. It can be noted that the anconeal process in this view does not have superimposition of other bony structures. Proper positioning for the cranial caudal view of the elbow or antebrachium is demonstrated next. The head is moved to the side so there's no superimposition of the neck area. The leg is extended cranial. The elbow is taped and pulled laterally so that the true straight position of the humerus and antebrachium can be maintained. The leg is measured and the beam can be centered either on the elbow area or the antebrachium depending upon the interest. If the elbow is the prime interest, it is a good activity to flex it so that you can be sure the location of the elbow area. The marker is placed on the cassette, and care needs to be taken so that the marker is not over the identification blocker. The more extension the leg has at the time of exposure allows a better visualization of the joint spaces. A properly positioned craniocaudal elbow joint shows the ulna centered over the distal condylar area of the humerus. The next area of consideration is the pelvis. The pelvis is one of the more frequent radiograph parts of the small animal, and this is primarily due to the high frequency of trauma and the interest in canine hip dysplasia. We will demonstrate 3 different positions of examination of the pelvis: the VD frog leg, the VD extended, and the lateral. The VD frog leg will be demonstrated next. The VD frog leg position is particularly beneficial in those animals that have sustained trauma, and you may not want to anesthetize the animal for the preliminary views. The frog leg position places less stress on any suspected fractures. You'll notice that the animal is in the V tray to control the thorax and abdomen. The legs are propped up with sponges under the stifle mid-femoral area to accomplish the well-positioned pelvis. The ilia and ischii are palpated in order to determine the limbus of the beam, and the marker is placed on the animal for identification, being careful not to place it over one of the bony structures. This shows a radiograph made in the VD frog position of a dog with a fractured pelvis. Note that the femurs are extended laterally rather than caudally over the ischii, as will be demonstrated in the next view, the extended view of the pelvis. Next will be the VD extended pelvis view. This position is tremendously facilitated by sedation and/or anesthesia. We will demonstrate the position of the animal without any manual restraint to reduce the radiation exposure to personnel. Notice that a V-trough is being used, which will control the abdomen and the thorax. Tapes are placed on each leg. Someone then rotates the stifles inward so that the femurs are parallel to each other. Then the stifles are taped in this position. The animal and pelvis is positioned properly. Note the sponge under the pelvis to help prevent tilting of the pelvis during the radiograph. The legs are then extended so that the femurs are parallel to each other as well as closely parallel to the tabletop. The beam must extend from the stifles to the proximal part of the ilii. The center of the beam should be over roughly the hip joints. A marker is placed on the table or the animal, depending upon the case. The animal pelvis is measured and technique properly set. This is the standard view which is used in the routine hip dysplasia examinations. This VD of the pelvis shows proper positioning. A properly positioned VD pelvis on the extended view must have symmetry of the pelvis. This is primarily determined by looking at the foramina and they must be of equal size and shape. Also, the ischii and ilii can be compared for symmetry. The femurs must be parallel to each other, and the proper rotation of the femurs is indicated by the patellas being over the middle of the distal femur. To obtain a properly positioned lateral view of the pelvis, the animal must be in lateral recumbency. Tape is placed on each foot, allowing positioning of the legs to be separated. The leg of primary interest or side should be down. The down leg is pulled forward and the upper leg is pulled caudally and blocked up so that the femurs are somewhat parallel by a sponge. The collimation must be from the proximal part of the ilium to the ischii. The greater trochanter indicating the hip should be in the center of the film. The beam must extend dorsal and down to about mid-femur. The animal is measured in order to set the technique. The radiograph is marked by indicating the down or forward leg. This well-positioned lateral radiograph of the pelvis shows the hemipelves superimposed over each other. Notice that the down cranial leg is closest to the R, indicating the right side was down. When a fracture of the pelvis is the main concern of the radiography, there may be some advantage of slightly rotating the pelvis so that fractures could be discerned in each hemipelvis without the superimposition. The next area for consideration is the femur. Two different views are utilized: the lateral view and the cranial caudal. Two different positioning techniques can be used to obtain the cranial caudal view. The most common method is the inclusion of the femur in the extended VD pelvis examination, which has been previously demonstrated. The horizontal beam radiograph is particularly useful for making post-operative radiographs where less stress should be applied to the extremity in order to obtain proper positioning. To obtain a lateral view of the femur, the animal is placed in lateral recumbency with the leg of interest down on the table. The other leg is taped and pulled out of the way. This prevents the superimposition of the other leg over the prime leg of interest. The beam must extend from the acetabulum to the stifle. The measurement is made in the hip area, which is the thickest part and must be the determining factor in establishing the technique. The beam can be restricted cranially caudal to just include the femur, reducing the exposure from the scatter. The center of the beam is on the midpoint of the femur. The marker is then placed on the table or the animal's leg over the fleshy portion. This lateral radiograph of the femur shows a fracture of the shaft of the femur. The stifle will be the next area considered. There are three different views: the lateral view, the cranial caudal view, which is similar to the positioning of a VD pelvis extended view, but the beam is centered over the stifle rather than the hip. A horizontal beam view can be made, and a caudal cranial view can be made with the animal on the table in a sternal recumbency and the leg of interest extended caudally. The lateral radiograph of the stifle is preferentially made tabletop using no grid. This allows for considerably less radiation and exposure of the personnel should they be required to be around. The leg is in a normal standing position. The other leg is taped out of the way, similar to the radiograph of the femur. The leg may be rotated slightly using a sponge under the hock so that a true lateral of the stifle can be obtained. The collimation should be from just above the stifle to just below the stifle. This small area lends itself well to placing radiographs of both stifles on the same film by splitting the film. This aids for comparison in many cases. Each leg is marked and the exposure made. This is a well-positioned lateral radiograph of the stifle. Notice that the condyles of the femur is superimposed. The patella is totally cranial to the femur. This is such a good view that if you can get all your films to turn out this well, you may get a raise. This next demonstration is the use of the horizontal beam for radiographing the stifle or femur. This same horizontal beam technique can be used on any portion of the extremities. The tube must be brought down and rotated 90 degrees at one end of the table. The film and cassette are placed in a holder at the opposite end. It is important that the proper tube cassette distance be maintained for the technique established. The animal must be elevated so that the part is in the beam in the proper location. This shows a caudal cranial view of the humerus and elbow made with a horizontal beam. In case you're wondering, this technique can be used on the foreleg even though we just demonstrated it on the rear leg. This particular technique is beneficial when less stress needs to be applied on post-operative radiographs or when the external fixation devices often interfere with the normal positioning. This demonstration of a caudal cranial view of the stifle shows the animal placed on their sternum and the leg of interest is extended caudally. It is a tabletop exposure. The opposite leg is propped up so that the pelvis is rotated, providing a more accurate view of the stifle. Tape is placed on the leg so that the leg can be extended. Tape is also around the hock, which provides a rotation correction for accurate viewing of the stifle. The tail is taped out of the way so it does not interfere. The stifle must be palpated so that the accurate positioning of the central beam can be placed. The collimation is just to above the stifle to just below. The part is measured and the technique set. And then a marker is placed on the leg just before the exposure. This is a well-positioned radiograph taken with the caudal cranial view of the stifle. The criteria for evaluation is that the patella must be well centered over the distal femur. Also, the joint space between the femur and tibia should be well visualized as in this radiograph. The femoral condyles should not be superimposed over any portion of the tibia. With the tarsus, usually two views are adequate, the lateral and the craniocaudal. On this next demonstration, we will show how to do both a lateral and a craniocaudal view of the tarsus with a split film and keeping the anatomical parts going the same direction. The tarsal area is placed on the film. A sponge is placed under the calcaneus to rotate the leg so that it is true lateral of the tarsus. The part is measured. The foot is taped down to the table so that the tarsal area is horizontal on the X-ray cassette. Following the exposure, when the leg is removed, a tape is then placed on the edge of the cassette, indicating the end of the cassette that has been exposed, and that tape also marks the toe end of the extremity. The animal is then prepared for the craniocaudal view of the tarsus. The animal is placed in dorsal recumbency with the leg of interest extended. The leg is taped to the table. Another tape is placed around the stifle so the leg can be rotated to obtain proper alignment of the tarsus for the exposure. The beam is then aligned over the tarsal area, remembering that we are on the opposite end of the cassette of the small tape which marked the previous exposure. The beam should be large enough to extend above the tarsus as well as down to the mid-metatarsal area. It is sometimes difficult to maintain the contact of the foot with the cassette, and so additional tape and positioning may be necessary. The marker is placed on the cassette. Ready for exposure. This radiograph of the tarsus in the lateral view is well positioned. This is a well positioned craniocaudal view of the tarsal area. The criteria for determining the positioning is being able to see the interosseous space, the dark line which is being pointed out, and not having the superimposition of the fibula over the tibia. 3 views of the foot are usually taken: the lateral, the craniocaudal view, and 1 or more obliques. The oblique views allow separation of the toes so that a greater visualization of the surfaces of the digits can be made. Since obliques are often more valuable than laterals in examination of the toes, this demonstration will show the dorsal plantar view and 2 obliques. We will use a 3-film split tabletop in this demonstration. The dorsal plantar view is done similar to the hock. Sandbags or lead gloves can be used to weight down the leg and hold in position. You will notice that we used cotton between the toes so that the toes would be spread slightly for better viewing of the digits. We have now moved to the second exposure. You will notice the tape that has been placed on the edge of the cassette indicating the first exposure. The cotton is still between the toes and the leg is in a relaxed position for this exposure. Following this exposure, the cassette is marked with a second piece of tape, and then we move to the third oblique. This oblique is made with tape holding the digits apart to separate the toes. This radiograph is an example of an oblique of the foot or digits. Notice how the digits are separated so that better visualization can be made of each digit. If you remember from the demonstration, this separation of the digits can be accomplished by either using cotton between the toes or by pulling the toes apart with tape. The next area for positioning assistance will be the thorax. Routinely, lateral views and either VD or DV views are taken of the thorax. Views at 90-degree angles give a better impression of what is going on within the thoracic area. With the lateral view, the animal can either be positioned with their right side on the table or their left side. Either way does not make much difference. The important part is that you need to be consistent in the way that you individually take them so that your anatomical visualization will become more uniform. With the VD-DV controversy or position, again, it's partly personal choice which you would prefer to do. Some individuals argue that the heart is closer with a DV view, therefore a more accurate image of the heart is obtained. There is the argument of which is the easiest to position, a DV or VD, and that may make a difference in your decision. The third criteria has to do with radiography of the animal that has severe dyspnea. It is normally less stressful to do those animals in a DV position rather than a VD. As we demonstrate the thoracic positioning, you will notice that this is the first time that we have shown manual positioning rather than the chemical restraint that we have shown previously using positioning devices and tapes. If possible, it is always better to use the chemical restraint rather than the manual restraint, since it allows the operators to be completely out of the room and free from the radiation exposure. In this particular case, though, with the thorax, it is often advisable to do the radiographs with the animal awake. There is less concern with collapse of the lung and giving an abnormal radiographic appearance if the animal is awake. You'll notice that the two individuals that are preparing to restrain the animal are protected by using lead gloves, lead aprons, and they have their badges outside the lead apron around the neck area. The third individual, who is assisting with the positioning by measuring, will then leave the room, set the machine, and make the exposure. The animal is placed in right lateral recumbency. The forelegs must be pulled and extended cranial. The rear legs are pulled caudally to place a slight tension on the thorax. The head must be maintained in a neutral lateral position so that the cranial thorax is not twisted. The pelvis must be maintained lateral to control the caudal thoracic area. The sternum must be equidistant from the table as the spine. Therefore, the use of sponges is essential to create this truly lateral position of the thorax. The radiograph will be from the thoracic inlet to the last rib, and the beam is centered over the heart. With a lateral view of the thorax, the criteria for evaluation of positioning is primarily the ribs. The ribs must be superimposed upon each other. This is particularly beneficial to look at the dorsal bow of the ribs as well as at the costal-chondral junction distally. The film must include from the thoracic inlet to a complete visualization of the diaphragm. The heart should be centered in the middle of the film. The radiographic exposure should be made on full inspiration of the animal. Full inspiration can be partially judged by looking at the distension of the main stem bronchi and the separation of the heart from the diaphragm in the ventral thorax. When using manual restraint and the animal is struggling, the technician has a tendency to lean on the animal to obtain restraint of the patient. This usually moves the holder closer to or into the primary beam, which increases their exposure to radiation. When you find yourself in this maneuver, chemical restraint may be required to allow the holder to move to a safe distance. With manual restraint, the holder must attempt to stay as far away from the primary beam as possible. For a VD radiograph, the animal is placed in dorsal recumbency. You will notice that the head is controlled between the extended front legs to help in maintaining the VD position. The rear legs are extended, placing a tension on the thorax to help in preventing rotation. The animal is measured as in the lateral view at the greatest thickness of the thorax. The sternum must be palpated so that the rotation will place the sternum superimposed over the ribs. The radiograph must extend from the thoracic inlet to the last rib. The beam is centered just behind the shoulders, so the heart is centered on the radiograph. The radiograph should be made at full inspiration. The criteria for evaluation of positioning on a VD or DV radiograph is 1. Seeing superimposition of the sternum over the spine. Secondly, noting the bow of the ribs so that they are equal on both sides and that each half of the thoracic cavity is equal to the other half, using the spine as the midplane. The positioning of the animal to obtain abdominal radiographs is almost identical to the thorax, except that the center of the beam is over the abdomen. Care must be taken to obtain true laterals and VD radiographs. DV radiographs should be avoided. The films are made on expiration because of a longer quiescent period, which allows for the exposure without movement. Dependent upon the purpose of the abdominal radiograph, prior preparation of the GI system may be beneficial, such as a 12-hour fasting period plus a cleansing enema. The animal is placed in lateral recumbency. Care must be taken that the sternum is at the same distance from the table as the spine. The animal must be measured at the greatest bow of the ribs, which is the thickest part of the abdomen. The thorax is the control of the cranial abdomen for positioning, while the pelvis is the control of the caudal abdomen. The beam is centered over the umbilicus of the animal, and the film must extend from the xiphoid of the sternum to the hip joint. The actual exposure should be made on expiration during the long quiescent phase. Watch the animal and time the exposure properly. This is a well-positioned lateral abdomen radiograph of a cat. The radiograph includes from the dome of the diaphragm to the pelvis. The criteria for evaluation are superimposition of the ribs, the same as in a thoracic well-positioned film. Notice the superimposition of the transverse processes of the spine, which was a criteria for a good spinal radiograph, and then the superimposition of the hemipelvises to indicate that the pelvis was properly positioned. You must use the same positioning for a VD abdomen as we did for the thorax. The forelegs must be pulled cranial and control the head between the legs, and the VD of the pelvis must be accurately positioned. The animal is measured over the greatest depth of the cranial abdomen, which is at the last ribs. If the mid-abdomen is measured and the technique set by that measurement, the film will be underexposed for proper interpretation. The film must be centered over the umbilicus and must extend from the xiphoid to the hip joint. A well-positioned VD abdominal radiograph will show the spine in the center of the abdomen. An error noted on this illustration is that the film does not extend to the dome of the diaphragm nor to the hips. If the size of the animal prevents inclusion of the entire abdomen on one film, two films may be necessary. This also allows you to adjust the technique for the thicker cranial abdomen versus the thinner caudal abdomen. This section of the tape has been developed to show you how to reduce the exposure to personnel working in positioning small animals. We have shown you most of the common positions in small animal medicine that are used for standard radiographs. The three principles which must be remembered in reducing personnel exposure are: number one, time of exposure. The time of exposure is best reduced by always doing it right the first time and therefore avoiding repeats. Whenever a repeat is necessary, it means that the exposure to the personnel is going to be doubled. The second principle is distance. For most of the positioning areas, we have demonstrated chemical restraint along with positioning devices and the use of tape so that the personnel can be completely out of the room at the time of exposure. With the personnel completely out of the room, this will provide the lowest dosage possible to those individuals. When the personnel must be in the room, then the third area of protection is shielding. We have demonstrated the use of gloves, aprons, and other protective devices whenever the personnel must be in the room so that their exposure will be as low as possible. Always think ahead and get everything ready, almost to the point of following a checklist prior to the actual exposure. You must consider things such as 1. Measuring the animal correctly and setting the machine for the proper exposure for the thickness and body part of the animal. Number 2, choose the proper cassettes, center the beam over the area of interest, and collimate the beam to the smallest area that will provide the exposure of the area of interest. And number 3, accurate positioning of the animal so that you will have a true anatomical representation for easy interpretation of that anatomical part. If you do all of these things, you will greatly reduce your exposure to radiation. This videotape is on the radiographic techniques and radiation safety training for veterinary technicians. The radiologists involved in the production are Robert Lewis, Mary Mahaffey, Barbara Seltzer, and Elizabeth Watson. All 4 are diplomates of the American College of Veterinary Radiology and are associated with the Department of Anatomy and Radiology, College of Veterinary Medicine, the University of Georgia. Technical assistance was provided by Tim Jarrett and Ann Toth. The production manager was Gary Burton of the Educational Resources Center of the College of Veterinary Medicine. This videotape was sponsored by the Georgia Veterinary Medical Association, located in Norcross, Georgia. Financial assistance was provided by the Atlanta X-Ray Sales and Service of Duluth, Georgia.